people in a medical fraternity. One who are basic scientists, other who are clinicians with a knowledge of basic science, and third who are pure clinicians. So now we ask a pure clinician to come up for our next talk. He is none other than Dr. Nagendranath Mishra, and we all know he has been a pioneer in the field of ICBPS in our country, and he would speak on ICBPS, a single center treatment experience. So welcome, Dr. Nagendra.
Make it okay.
So we are running short of time, so we'll try to keep it in time.
Sure. So I'm thankful to the organizers for giving me this an opportunity. Now, see, whatever I will be talking is purely my experience. Maybe it is different from what you read in books. It's not moving. Okay. So the first case of interstitial cystitis I saw in 1993, and cystoscopy was done in 1 minute. Sorry. So we have done cystoscopy in 478 patients. I have seen more than 1,000 patients, but I am only taking those patients where I have done cystoscopy. So let us go to the timeline. In 1993, I diagnosed first case of interstitial cystitis, but it was not first case in India. In 2004, the first commercial manufacture of pentosan started in India. In 2005, I founded International Painful Bladder Foundation with Zane Mesling in Netherlands. And in 2005, we put up a stall in Ahmedabad UCCon conference for training the urologist. And we wanted them to be aware of this disease. In 2007, first ICBPS symposium was held in Patna, and I chaired that meeting. In 2009, I think Vishal is there or not. Vishal came to me and he asked help in getting his pentosan polysulfate accepted in India as a drug, and he wanted me to make it popular among urologists in India, and I did that. That was in 2009. And 2009, I wrote a book on interstitial cystitis, which was released at Agra. So then another thing was the development of intravesical tacrolimus in 2013. That was a major milestone. And in 2015, it's like after 22 years of me working on interstitial cystitis, GIPS was established. And GIPS did a very good job of interstitial cystitis awareness among gynecologists and urologists. And in 2022, few days back, I had a meeting on intractable interstitial cystitis. So these are some of the pictures of the 2005 meeting this was a meeting in 2005 in my clinic where Jane met the patients. And in 2007, I think Rajesh remembers, Jorgen Nordling came from Copenhagen, and we had a meeting on interstitial cystitis. Now, in 2009, I think Vishal remembers, we had a meeting in Pune, and we framed an Indian definition. This Indian definition is recurrent pelvic pain or discomfort of at least 4 weeks duration. We have also added burning and throbbing, and these symptoms are related to bladder filling. And we are able to diagnose like 97 to 98% patients with this condition using this definition. And this was the presentation which I did in with Drug Control of India. Vishal, you must be remembering. For Camphora, I did the presentation in front of Drug Control of India, and the Camphora was recognized in India, and it was used, the sale of Camphora started in India. Now, there are the AUA guidelines, as I told, I don't follow, and I have also published this in a journal, so the reference is my own. In a latest journal, I have written that I don't follow ICU, Interstitial Bladder Pain Syndrome guidelines of AUA, because they are not evidence-based. Now, what not to do. The first 4 have already been presented here, and I have added some more like hydrodilatation, then HD under anesthesia at short interval like every 1 to 3 months. I see patients where hydrodistension has been done every month. So I don't recommend that. And pain-filled procedures like potassium test, office cystoscopy, or urodynamics, I don't recommend. Now, my hypothesis of etiology is different. Abnormality of detrusor muscle stretch is responsible for bladder filling, responsible for the symptom of ICBPS. Physiologically, the bladder fills to adequate volume and the detrusor stretches to accommodate that amount without an intense desire to pass urine. In a patient of BPS IC, when the bladder contains only 20 to 50 ml of urine, due to abnormality of detrusor stretch, bladder senses overfilling and sends signals to the brain to initiate micturition urgently. In a normal person, this sense of urgent micturition is sent when bladder fills to 300-500 ml. This hypothesis is the basis of success of augmentation cystoplasty alone surgery in patients of ICBPS. This is also published and it is my own reference. Now, how to diagnose? It is a clinical diagnosis. No investigation can diagnose ICBPS. Need investigations to rule out other diseases. Now, there is a 3-step diagnosis. Any patient coming to me, I ask 3 questions. Is it necessary for you to void if you once get desire to pass urine? Does the pain increase when bladder is filling up? Does the pain decrease when decrease or goes away when you finish voiding? If USG, QB and PVR is normal, and all these 3 questions, the answer is yes, then I am dealing with a patient of interstitial cystitis bladder pain syndrome, until unless proved otherwise. So my algorithm for ICBPS is very simple. We do a cystoscopy, diagnose Henner's lesion, non-Henner's lesion. Henner's lesion, we do coagulation, and then if they do not improve these patients, we do surgery. And if there are some patients which have minimal symptoms and they are not improving, we may do Botox, or we may do Interstitial or anything, or we may give cyclosporine A. So my algorithm is very simple. So these are the mandatory investigations. These are the differential diagnoses. I recently saw 2 patients of urothelial dysplasia presenting as interstitial cystitis. So I have just added them. So cystoscopy is mandatory because we can diagnose other treatable diseases with it. And we can do therapeutic hydrodistension at the same time. And how to do cystoscopy, I think this august crowd doesn't need any direction on that. Now, can bladder be normal in cystoscopy in ICBPS? The answer is yes, yes, yes. Please don't say a patient that because your bladder is normal, you are not suffering from interstitial cystitis. So I do a stage treatment. First stage is hydrodistension at the time of diagnostic cystoscopy with oral therapy. Second stage is intravesical therapy. Third stage is reconstructive surgery. Botox, ineffective in my practice. No experience with Interstitial and physical therapy. Lifestyle modification is part of each stage. So this is how I do hydrodistension. Now I use triple drug therapy, amitriptyline, hydroxyzine, and gabapentin. All patients take this treatment for 3 months. Depending on response, dose can be adjusted. Pentosan given in only few patients in OD or BD or TDS dose. Doubtful evidence for effectiveness of pentosan. Black box warning for pentosan by US FDA for irreversible retinal maculopathy. Never use it for more than 1 year. Intravesical therapy is second stage. And either I use a intravesical cocktail.
The time of your talk is going to be over.
Okay,
Thank you.
Okay, professor, you give me little less time. So there is a cocktail intravesical therapy, and then I use intravesical tacrolimus. It has got reference in other journals also. Now, HL and NHL are non-Henner's lesions are different. Like in a Henner's lesion, the bladder capacity will normally be less. The average age will be more. The Henner's lesion patients will take more time and more number of therapies for treatment. They will need more surgeries. So surgery, augmentation, iliocystoplasty alone. 15 patients underwent augmentation cystoplasty alone in last 22 years, 6 males and 9 females. 4 patients died due to unrelated cause. Follow-up of 10 years to 3 months of living patients. 5 had Hunner's lesion, 6 had non-Hunner's lesion, and 4, it is unknown. 3 had small capacity bladder less than 200, 2 had 200 ml capacity, 8 had normal capacity bladder 300 to 600 ml. 2 cases, the capacity is not known. 3 patients have moderate improvement and 8 have marked improvement. So there is minimal morbidity in all patients, 9 patients void and 2 require CIC. With disappearance of dyspareunia and painful ejaculation, sex life becomes better for all except 1 patient who had no change. None of the male patients developed impotence and none of the female patients developed dyspareunia post-surgery, as there is no vascular or neurological compromise due to surgery which involves minimum dissection. So in my hands, I really don't know why all these patients improved, but all my surgical patients have improved. And we had a meeting, Sanjay was also there, Shailesh Shah was there, where we discussed in length. And I personally feel that surgical therapy should be recommended in interstitial cystitis in a severe case. So my long-term results are very good. And for the gynecologist, we can give PPS, amitriptyline and intravesical heparin in pregnancy. And this is my paper, which has been published last month only. And just look at the conclusion. I am trying to change the thinking of treatment of intravesical of interstitial cystitis. Long-term results have been encouraging for ICBPS patients. Unfortunately, Hunner's lesion patients need a more intensive treatment regime. Re-evaluation with cystoscopy is recommended in non-responders. In spite of good results of surgery, I don't recommend immediate surgery. I recommend surgery only when all other things have failed. So this was the meeting, was done last Saturday. And we define intractable IC means you do anything except for interstitium or surgery, and the patient is not improving. It can be called intractable interstitial cystitis. There is no definition of this intractable interstitial cystitis anywhere given in any book or anything. We did a big survey on that. Now this is a take-home message. The negative mindset associated with management of ICBPS has to be changed to positive one. The advice to the patient should be that she will improve provided he is ready for multiple modalities of treatment, but we do not guarantee cure. Surgery is also one of the good options. Result of surgeries are better than other modalities of treatment. One common factor in various series for persistence of pain after surgery is long history of disease. So there is a need to offer surgery as soon as all the conservative modalities have failed. Patients, even with large capacity bladder, benefit from surgery. Both HL and NHL patients have severe disease, maybe more in Hunner's lesion. Persistence of pain in 1 patient should not deny chance of good life in 99 patients. So I will again repeat this. Persistence of pain in 1 patient should not deny chance of good life to 99 patients. Pelvic muscle spasm is secondary to primary bladder disease, interstitial cystitis, BPS. Cystoscopy is done, should be done by most experienced urologists, not by the resident trainee. And timeline is to be fixed for surgery. And I thank Sanjay, he must be knowing, I have changed many of my terminologies in this on his advice. Thanks a lot.
Thank you so much. Having heard single center experience.